So welcome again, everyone. This is Rob Love with Love & Company. I've really been looking forward to today's webinar for quite a while now. It's been in the planning process for a bit, and we get lots of feedback, positive feedback about our webinars, lots of ideas from you afterwards for things you'd like to see, and we really appreciate all that. And today and next month in September, we're beginning a two-part series where we're really going to take a look at the competitive environment that we're in and share some ideas as to how our communities can really reposition themselves for success over the coming years. So hope you enjoyed this one, and thank you again for joining us today. A couple of quick logistics before we delve into things. First, we will answer questions at the end, but you can submit them anytime during the presentation. If you look at the menu bar for the Zoom application, you should see a Q&A option there. If you click on that and open it up, you'll be able to type in your questions, and we will gather them up during the course of the webinar and be able to address them at the end. Lots of times people will inadvertently pick up the chat and put a question in there. We may ask you, if that happens, to please copy it back into the Q&A so we can work from that one place for them. Now, of course, the most frequent question we always get is, will we get a copy of this presentation? And I want to let you know that at the end, we are recording it. And a copy of that recording will be emailed to all of you, and will also be emailed to everyone who registered for the webinar. That's our standard practice. So yes, we will be sending this out, and we encourage you to share it with others in your organization as you deem appropriate. So our plan for today, we'll start with introducing our speakers, and then talk a little bit about why we feel this topic is so important. What are some current trends in health and wellness that are outside of senior living that we really need to be aware of and think about as we look to shape our own future? We'll delve into higher levels of care and what's really happening there, and how we should be thinking about that, and what questions we should be asking ourselves as we try to figure out what the right mix of higher levels of care is for each of our communities. And then lastly, we're looking forward to sharing some thoughts on the proverbial fountain of youth and how our life plan communities are ideally positioned to be able to provide a health and wellness platform that no other senior living or really senior healthcare alternative can provide. So that's our goal for today. I'd like to start off with introductions and ask our panelists to introduce themselves. So Karen?
Yeah, thanks, Rob. So I'm Karen Adams. I am Vice President of Market Intelligence with Love & Company, where I've been for 3.5 years now, and delighted to be here. Prior to that, I had 40 years in the same type of role on the West Coast. So, thank you.
Thanks, Karen. And we're very pleased today to have a Love & Company alum with us. So, Tom?
Hello, all. As many of you know, as Rob stated, I was with Love & Company for many years, and prior to that, was with Erickson for many years, and now I am back on the operator side and am serving as the Vice President of Sales and Marketing for Moorings Park Communities.
Thanks, Tom. And Mike, I think we would like to consider you an honorary alum, because while you've never actually been an employee, we've worked together for probably, 15 years now, a large chunk of which when you were an independent contractor. So it's been a great relationship, and we really appreciate you joining us today. So if you could just take a moment to introduce yourself.
Thank you. Appreciate that, Rob. Scarily close to an employee, I guess I would say. Mike Kivov, founding partner with 1 Point Partners. We are a diversified advisory firm within senior living and care, providing strategic, financial, development, and also operations advisory and solutions for our provider clients.
Great. Thanks, Mike. And of course, I'm Rob Love. I'm the owner of Love & Company. And if you were new to our webinars and new to us, just very briefly, we are a market research, marketing, creative, branding, lead generation, and sales consulting firm that specializes solely in the senior living field. So we welcome you to today's webinar. So just to begin, let's have a short conversation about why is this important? And what we're seeing in the field today is just steadily increasing competition from all sorts of sources that really may not have been in the marketplace or in our awareness a decade ago. But over the coming decade, they're going to be huge, they have huge impacts on us. First, certainly, we see, life plan communities see a lot of rental independent living. There's been way more growth in rental independent living over the past 10 years than there has been in the entrance fee side of the field. In addition, there's just been huge growth in a variety of services that are available to seniors in their homes and able to extend their lifestyles there. And then, boy, this last year more than ever has introduced and made just right at our market's fingertips a plethora of on-demand services, so that today at home, seniors can get almost all of the services that 10 years ago, they had to come to us if they wanted all these things packaged some way. Now they can get them immediately. We're also facing competition from other sources. For the last several years, active adult communities have been taking a very hard and strong look at the aging population, looking at the boomers and wanting to create and design a product that provided the technology and the physical design that really enabled people to age in place. So they are directly taking us on as well. And hand in hand with the active adults is just huge growth in smart home healthcare technology. As this graphic states, it's been projected to be a 40% almost compound annual growth rate of smart home healthcare sales in the US between 2018 and 2023. So we are just getting competition from all types and all sides. So to us, some of the key questions are, how can life plan communities evolve to stay relevant and viable in the decade ahead? And that leads to the more direct question, what can we do meaningfully better than these other alternatives? That's what we're looking forward to exploring with you today. And today, as I mentioned at the beginning, is really part one of this. And we're going to focus first on the healthcare continuum and how that's evolving and how we need to be thinking about that differently in the future. But then even more importantly, to really create a unique and dynamic niche for our communities, how do we find the right balance between care, which has been our historical message, we were continuing care retirement communities, to one of which wellness and prevention and life extension, as we'll talk about later, really becomes a predominant part of our messaging. Next, in September, we're excited to announce that we're going to pick up another similar topic of unique differentiation that life plan communities can provide related to social connection and engagement. And joining us for that one will be John Franklin of Pearl Creek Advisors, Kyle Robinson of Walzesta, and Gwen Hardy and Cameron Honeycutt of Presbyterian Homes of Georgia. So if you get excited today, please come back September and for part two of this. So with that as the background, Karen, lead us off, please, and share some of the current trends. And give me just a second to make sure you have control of the screen. Okay.
And I do not.
Let's take just a moment to transfer.
And again, so it's about patience. Sometimes it takes a minute, and I am weak in that category.
Okay, well, I'll move it forward one, see if that.
I think we're okay. I think we're okay.
Okay,
So trends being one of my absolute favorite topics in the field. And to do it in healthcare has been very fun and interesting topic. And for me, whenever I think about trends and evolution, one of my biggest questions is, how do our markets want to use and how are they using elements of what's in their life now, even outside of our walls. So what is going on? What are the patterns and trends in the broader world that have implications for us? And secondly, I think one of our biggest advantages with our life plan communities, of course, is the continuum. So thinking about how our residents, our prospects, want to take tools that are available and continue to build them into their own lives, and how they want to create the balance across living levels that they have available. What are their expectations given their life experiences generally with new tools and new technologies and new trends? So let me give you two examples before I launch into them, just to illustrate that. And one is assisted living. We have had that, our continuums have had assisted living usually long, long before we thought we invented fire for the second time with standalone assisted living communities. We've had them as our part of our continuums, although they certainly didn't look like the new product that is available in the market in many instances. And the new assisted living that's out there tends to have more robust kitchens, perhaps more storage, tends to be more apartment-like, rather than rooms and private baths, or even small apartments with less robust kitchens. We, in the continuums, began to shift into home care, and that's been very well received, and it's a trend that's really been accelerating. So what we're experiencing as we go back out into the world these days is repeated times bumping into the assisted living product and whether it has been revisited to address people's expectations for what they see in the broader community, and also what their expectations are about how they want to live. So I'm going to talk a little bit about what we see happening there and some of the implications for it. But again, the things that exist out in the broader world begin to impact how people will behave on our campuses, which then impacts us. The second area is food. Well, food's sort of a winner all the time because it's evolving constantly, because it's so much a part of all of our lives. And the trajectory in our field, I've been around long enough to have actually watched this in my lifetime, went from 3 meals a day, we take care of you, we provide nutrition. And it was, well, you could call it nurturing or you could call it paternalistic, whichever you choose. But either way, it was, we cannot possibly do that because we need volume to offer choice and to offer not doing 3 meals a day. But we did finally evolve into having 1 meal a day. And from there, we figured out that we could do 20 meals a month. And then we went to country club and debit card models. And we began to figure out that we wanted dining venues and not dining rooms, that this was about an experience, and we have chefs. So there's been this enormous evolution over the last couple of decades. Farm to Fork then came on board and also took off like wildfire and has been very well received. But I'm going to bring up to you another where I believe food is going now. That's a next evolution that comes again from this concept of what people are experiencing out in the broader world. So how can life plan communities evolve to stay relevant? Well, for me, a lot of the answers are in looking at people's life experiences outside of our walls. There are plenty of programs and trends in health and wellness. I am not touching nearly all of them. So they're just ones that we have been seeing as we're back out on campuses, and then certainly this food topic. Okay, Rob, did you give control back to me, or because? Okay, thank you. Very good. So the first trend we've really been watching going on in the world is healthcare goes remote and retail. We can really see this in the enormous growth in the use of telehealth. The pandemic certainly was a rocket ship launching that into higher use, but we also have commercial pharmacy clinics that people can make very rapid appointments and go to the corner pharmacy for many of their healthcare needs. We have membership programs that provide physician house calls. We have people's acute or general healthcare and preventive care very much going remote and retail. And what are the implications for us on our campuses? Well, there really are some, because programs to support remote and medical care might include assuring that we have good and adequate bandwidth. Do we have the highest quality video for that interaction between a healthcare provider and our resident? Or do we have a space that very good quality, high bandwidth and good quality video can be accessed? The technology to support residents, they might not know how to easily access that. They might run into problems. Do we have available the tools and some individuals that can help support in the use of technology? Because we're all using it out in the world, we're going to bring it with us. A health advocate, do we have somebody that can sit by individuals and help them through the process? And an on-site assistant, somebody who might take blood pressure, help ask questions, again, support the resident in the use of these technologies. Now, for a lot of you who have joined us for our webinars, you've probably seen this slide because it comes out of a survey we did with waitlist and depositors. And it's the use of telemedicine that really struck me, and a reason I continue to use this, which shows us that during the pandemic, 45% of our respondents, which were over 1,200, were not using it previously, but started using it once they were in a stay-at-home mode. Once, I hate that term lockdown, but once that kicked into our lives, 45% said they began using telemedicine. So that's not going away. Of course, Medicare reimbursement kicked in as well, also not likely going away because of the benefits of this tool. And 25% are not using it but would like to. So that's a 25% additional opportunity, but we're going to see most people using this type of tool, which of course really depends on the level of the healthcare need. You know, the more serious, obviously, the less telehealth is used, but telemedicine and telehealth will be used for a great majority of healthcare needs. So the next one is home care and home health care. As I mentioned, we've really seen enormous growth towards delivering services and assisted living services to people in their homes. And there are a number of implications here. So we have a real shifting of the continuum. So what we have is home care is becoming assisted living. Extended congregate is beginning to really, in many places, replace skilled nursing. And by that, I mean a higher level, being able to serve a higher acuity of resident, but still not needing those nursing beds. And again, these are driven by consumer desires and demands. Once we started pushing healthcare or home care and home support out to the independent living residences, that's what a lot of people wanted. And so that picks up growth very rapidly and snowballs. So we've seen this shift in the continuum, and skilled nursing is by and large becoming mostly post-acute care. So we do have this shift in our healthcare end of our continuums. Now, implications from home care and home health care. This is what we're experiencing newly in some ways on campuses, just since we're really starting to get out and about again. We're hearing some concerns about spend down on home care with communities, that people are spending down on home care in the independent living, then coming to nursing where they either need to convert to Medicaid or are more dependent on benevolent care. So it's an early concern we're hearing, but what we do see much more consistently is a tendency to delay that move across the continuum, and many times leapfrogging our assisted living communities. There are some implications if we don't own the home care, if we aren't a partner in the home care. There's loss of revenue if it's not yours. And one of our bigger concerns right now may be loss of data for projecting campus healthcare needs. We really need to understand that utilization to balance our communities, which when we talk about rebalancing nursing, we have a lot of data. The actuaries have, volumes of data to help us rebalance. We don't have that same thing regarding home care. So if you aren't controlling it, you lose control of the data of the utilization of that home care. And again, this leapfrogging of assisted living into nursing. And this is where I go back to what are people's expectations from what they see out in the greater world and environment. Are our assisted living community, are our assisted living components keeping pace as a product? Are we updating those? And the ones we've been seeing, it's been a real question. So are people leapfrogging them because the product is just not residential? It becomes institutional, and we've even left it go for a while, so they're less attractive. So revisiting that piece to say, will people sort of use that more if we are meeting those expectations and revisiting what our products look like, because we are seeing this leapfrogging. So within skilled nursing, we have real pressures to change the model. I mean, it's not news to anybody that the pandemic has said the greenhouse model and small house models make sense in a pandemic. We can isolate people into smaller pods and still keep a lifestyle. A lot of things about the small houses and greenhouses that make enormous sense coming out of pandemic, but it made enormous sense before because it is a consumer preference. The greenhouse guys had done studies years ago talking to consumers, and these were very, very attractive. So that model has more and more pressure to implement it. But one of the other things that I'm hearing anecdotally in the field is a shift from the small houses to the official greenhouses, which interests me because we've seen a lot of using that model, but not being an actual greenhouse. And when we're working with greenhouses right now, one of the issues is staffing. And if we're using universal workers, can we shift our staffing so that we don't need as many in like licensed categories? And does that allow us to maneuver our staffing better to meet our residents' needs? So there is this pressure and this growth in small houses, but particularly in greenhouses. And again, this is things we're bumping into on campuses repeatedly these days. We have real pressures to change the model, which we know. There is some speculation now for those of us who've been around a while. This stuns me because it has been so long since we've really heard anything of growth in nursing homes. But looking out in the field, and particularly at professional journals and things that are going on, there's actually some speculation of nursing home shortages in the future. And this really probably has the most implications for providers who still continue to have a significant number of nursing home beds. And everybody's looking to downsize, but it may be to really take a look at what's going on in your market and whether there's some opportunities there. The bankruptcies and closures on the for-profit side are taking beds offline. One of the things that really caught my eye is lease rate pressures. So many nursing homes are owned by REITs, and the lease rate pressures have been increasing, creating, again, defaults and sales of beds. We've seen over the last number of years sales of our nonprofit communities selling some nursing homes. And then, of course, pressures of decreasing reimbursement and states implementing programs to keep people at home, just like we're all trying to do. So we watched in the beginning as we started to say we can decrease utilization on nursing homes, but we now may be reaching that tipping point of looking at what we need to do to make that model work the best way it can. And are we reaching some kind of equilibrium, or will we? I think is more the question. Implications, again, as always, are going to be the underserved and the need really to continue to think about how we implement navigators, coordinators for services to, again, allow people to stay safe and healthy and happy in the least heavy care level. And so, thinking continuing care at home is certainly one model to think about across all of our populations. Last but not least in this category is, again, looking at the journals and literature. I've been pretty amazed to see that we think we're inventing fire for the second time again. We've had continuums for a very long time, but there's a lot of talk going on about skilled nursing as a continuum. So it's not organizations that are looking at being the full continuum, but are saying, oh, brilliant, skilled nursing can be assisted living, and then dedicated specializations, cardiac, pulmonary, inpatient dialysis. So again, we have this continued targeting of private pay and the insured, number one, but we also have the creation of continuums at levels of care that we didn't necessarily create the integration in the past, where we have in our traditional continuums. So that's on the healthcare side, things that we're seeing out in the field and listening to. The other topic moves much more into wellness that I want to talk about. And again, our trajectory was really the sustenance, 3 meals a day, to moving along the continuum into dining as an experience, dining as venues rather than dining rooms, then farm to fork. But the next level of this, I believe that's here, and we'll see being big right around the corner, is food is a way by which I can control my own health and wellness, and even food as medicine, that it will remain an experience. This is not about heavy, complicated diets and calorie counting. This is truly delightful dining with health and wellness. And I think that our markets see it and are going to see it more and more, and it's something for us to pay attention to. So basically, what is getting a lot of hype, and it's science-backed hype, but I don't mean to use hype negatively, is the influence of nutrition and lifestyle on our health status. I mean, so there's a lot of information out there now that 60% of our autoimmune system lives in our gut, and studies about the gut biome and its effects on our health and its effects and ability to avoid and minimize and delay and even remove chronic illnesses, even cure chronic illnesses. So we have an increasing understanding that plants get their nutrition from soil, and that industrial agriculture has really been focused on volume and size, big, beautiful growth of things, and not so much on nutrition. And what we're finding now is that even our most beautiful produce is depleted up to 60% of its nutrients. And this is really, really capturing the public eye. So we see it, we hear it in innumerable podcasts, in cooking shows, in magazines, in travel things to farms, and even in ads. Once it gets on your radar, you start to pay a lot of attention to it. And even in a pharmaceutical ad, they had people wandering happily around the farm environment, and then they also used the beach environment. So we're used to the beach environment being seen as this really positive place. Farms are emerging as really important components in our life. So farm to fork is kind of now just a given. What it's going to be about is sourcing of our food. The bottom line is, where do we source our food that provides really good quality nutrition? So traditional farming methods impact the soils and therefore nutrition, and food can be both preventive and curative. Okay. Sorry, I got a little ahead of myself on there. Okay, so what we're seeing that sort of really caught my eye, for that it's very real to us. Of course, the sourcing of food, and people are going to want to see that, and I think it's going to be of more and more interest to people. But we're seeing a growth in agrihoods and farms. And agrihoods are neighborhoods built around farms. And we're seeing in the Urban Land Institute is looking at studying this and doing a lot of work in this area. And when you, so now we're seeing it with active adult communities are building around agrihoods. There are 200 agrihoods in 28 states. We have these communities where active adult communities are selling that actual benefits of the food sourcing, but it's also about opportunities for intergenerational programs. It's opportunities for engagement with our broader communities. So there, when you really start to look at this, there's a whole possible blossoming of things. Then you go just to our continuums and our world, and guess what? We're able to find farms in our community. So Cornwall Manor in Pennsylvania has just created a partnership with the Rodale Institute, which is an institute that studies farming and nutrition. And they are about to open the Rodale Institute, Cornwall Manor Rodale Institute Trails Farm. Virginia Mennonite Retirement Community is even bigger, and they have the farm at Willow Run, also in Pennsylvania. Enzo Village, people all over the field have been hearing about Enzo Village, the Zen community out in Healdsburg, California. Part of their campus is an urban farm, much smaller, but it's an urban farm. Garden Spot Village in Pennsylvania has been way ahead of this, but in aeroponics. And then hydroponics is starting to emerge with products to bring into our community. So this whole concept of where we source our food and its quality, but also as the environmental qualities it can bring us are an emerging area. So not all communities can or will have a farm, but all can consider collaborating or sourcing. And then I just want to take one other minute. I don't want to run us over, but I just also, you know, we see all over on our radar is climate change. And this is never lost on our markets. And it all starts to weave together because then you start to hear about carbon sequestration in the soils. And then you start to hear about big farms changing their methods, which is very difficult to do, but you know what? They're changing their methods because they can make money on carbon sequestration. So we're going to see this move towards what our food quality looks like kind of across the board and in the big external world. So I think it's really worth paying attention to this one, and also the potential for a really great activity, a great engaging our residents, intergenerational, and I'm not doing that, so I'm sorry. So again, I just wanted to raise that the fact that all of the climate change is going to dovetail into people's understanding and what they hear about this. So thank you for your time. And I will like to hand this off to Mike, who will bring good practical things to the discussion.
Thanks, Karen. Rob, I don't know if you said you wanted to intro anything real quick, or do you want me to just dive in?
No, that's okay. Go ahead and jump right in. Thanks.
Great, thank you. And so many great trends, Karen. I was furiously taking notes while you were talking, but I'm going to speak a little bit about the impacts of this evolving model of care and service delivery overall within the continuum, how it's actually impacting long-term care and post-acute care. You mentioned some things about the shifting acuity and continuums and so many topics that are, you know, really great segue to some of the trends that are impacting long-term care delivery. So a couple of points just, I think, to frame up the conversation that'll be helpful. One is that I think for most life plan communities in particular, this isn't really a question of either or. This isn't we're doing wellness or we're doing care. It's really about how do you integrate it in a way that's right for your campus and your consumer. And we're really lucky today to have Tom with us from Moorings Park, who I think is such a exciting example of a community that's really embraced both sides of this equation. They're known for incredibly high quality care, but they're pushing as hard as they can at the other end about wellness being preventive and trying to keep people out of that care. So I think that the answer for most communities is going to be some integration of what is right for you. So no surprise here, there isn't going to be this, hey, you know, reveal today about here's what you do. It's really about orienting yourselves to ask the right questions to get to what is right for your community. So we're going to hit on what some of those key questions and considerations are, and then try to tie it all together at the end by talking a little bit about some actual providers that are in the soup with you right now, and how are they looking at it, and how are they trying to answer some of these questions. Okay, so one of the very first questions to me is right sizing. And this isn't just simply, running numbers about how many beds of something can you have, although that is part of it. This is really a complex determination. A lot goes into this, figuring out what of each component of care is right for your community. And when I say community, I mean on your campus, but also really your broader community. So market demand absolutely goes into this, but mission too. What are you trying to accomplish in terms of who you serve? And does that influence, for example, some communities have nursing beds specifically because they serve a Medicaid population, and that's mission driven, and reducing that is going against the mission, even though you might say that might be going with where the industry is, or in terms of proving the operation. So you've got market, but you've got mission, and then of course you've got the operation and the financial implications. Life care communities, just bottom line is, when folks matriculate through your system and they wind up in care, generally speaking, the financial outcomes for the community are not desirable. So how do you balance that? As a life care community, do you look at this differently when you start talking about internal demand versus external demand? How many folks do we want coming through our system versus how many folks do we want to serve that are coming from the outside market directly? And what is the right equation for us? If a fee-for-service community, little more flexibility in terms of maybe that payer mix and payer model doesn't change as much. Big deal financially for a life care community to figure out what is the right mix for us operationally and financially. Another core question for me is asking, what acuity do we actually want to serve? And we have a little question that we call, are you pre-acute or are you post-acute? And it doesn't mean you have to be one or the other. You can be both. The idea being that traditionally, the nursing setting and then related settings like even assisted living in more recent years really is part of the post-acute care environment. Most folks moving in there are coming from an acute care episode, and they're matriculating through the continuum from the acute care perspective coming down. And then there's the independent living side of the spectrum, which has always traditionally been capturing folks before they're into the continuum of care and coming upstream, so to speak. And wellness is going to be making even more of a really intentional foray into that pre-acute, getting folks before they enter that umbrella of healthcare, trying to prevent them from needing as much of that umbrella. So pre-acute, post-acute, what's right for you? How much are you doing of each, or what do you emphasize of each? Karen spoke a little bit about assisted living, which to me is such an interesting X factor for a lot of communities. And Karen, I think you used the term leapfrogging, how a lot of communities are actually finding that maybe they can leapfrog the assisted living. And I think that's fair to say that's on a lot of providers' minds that we talk to, particularly if their assisted living is a little bit more of the moderate acuity. You start to ask the question, how much do we actually need this bricks and mortar assisted living? Can we bypass this effectively through at-home care platforms or other ways where, as we like to say, assisted living isn't necessarily a place as much as it is a service? Do we need a place in and of itself for assisted living, or can the needs of folks that have assisted living, can assisted living needs for folks be met in whatever setting they are in, whether that's in their independent living unit or out in the community or wherever they might be? It's a really interesting question, and for some communities, it gets down to, do we try to free up space that maybe that assisted living has been occupied, and do we really need that in the future? Now, conversely, some communities look at this equation and they're actually saying, maybe we could use more assisted living, because we're looking at this as uber high acuity assisted living, backfilling what traditionally has been more of our long-term care and nursing. Tom's home state, well, not home state, adopted home state there of Florida. They have the extended congregate care license, similar licenses in other states. And Karen, I think you touched on this in your presentation as well. There's more out there for, if you want to push the envelope on assisted living to really high acuity, to continue to meet that shifting acuity cycle that we see, you can do that. And it begs a really relevant question of, can we meet a lot of the needs that traditionally have been in our nursing home in a more cost-effective care setting, both for the consumer and for us as a provider with very high level assisted living. And I can think of a number of communities that have actually moved in that direction, backfilling, downsizing of their nursing with more assisted living. Then long-term care nursing. Wow, this is, if this isn't a core question, I think, for everyone, just nursing in general, but in particular long-term care, where does this fit for you in the future? And I think just about every provider we're working with right now, this is a central question about solving for that future state of what you're going to look like and what you're going to provide. If and how does nursing fit into that? I think it's fair to say that everyone understands the nursing community has been exceptionally hard hit by the pandemic. But the reality is a lot of the trends that are out there were happening before COVID. A lot of the trends about decreasing utilization, occupancy going down, more challenging operating environment, staffing, all of these things that were there have only really been heightened by what we've seen with COVID. And the result is that this platform on the whole has taken a real hit. And you have to ask, how far does it recover? And if and when does it recover? Is it ever going to look like what it did in 2018 or 2019, let alone 2014 or 2015? We have seen some providers that have rebounded, and we've also seen some providers whose census has rebounded, but it's been at the expense of the quality mix, where it used to be, Medicare or private pay driven. A lot of the beds that they've lost, they've rebuilt census turning to Medicaid. And that's a solve in some cases, but financially, it's a very different outcome and a very different model. So how is that going to impact you moving forward? Is the ability to drive census really dependent on doing that with Medicaid, or can you get back to the kind of quality mix that you had in the past? Now, a little bit on the flip side of this conversation, Karen had also mentioned this trend. Karen, you stole all my trends, by the way, but I'll do my best here. The idea that could we actually be seeing decreasing competition in the nursing environment because the industry is it's just gotten so hard out there that some folks are going by the wayside. A lot of people are reducing the size of their nursing units. Bad operators, and this is not a bad thing, but bad operators or suspect operators are being shaken out in some cases. So does this actually create an opportunity if you're really solid on your nursing operation and confident in it, know what you're doing, provide good quality care, are you going to have less competition in the future? A great example we can think of is we're pretty familiar with the state of Connecticut. And this is a little bit of a careful what you wish for kind of argument. We've heard for years that the states would love everyone to move away from nursing. Stop sending our Medicaid dollars to the nursing environment. Let's use home and community-based services, just any other way to allocate Medicaid so that we're not doing that at the nursing home level of care where it's extremely expensive for everyone. And then you have examples like the state of Connecticut where they are currently inundated with applications from providers to reduce or get rid of their nursing components to the point where they're saying, whoa, wait a minute. We didn't mean everyone get out of the business. We want the good operators to stay in there. We just kind of hope the not so great operators would move out. But it creates a really interesting dynamic of wondering if you've actually created more of a need for yourself if you have that really sound operation. But how does it impact you financially? Again, if it's at the expense of payer mix, you have to look very long and hard about, are you sustaining beds in a way that, are you maintaining census and beds in a way that is sustainable for the financial operation? And then within nursing, we have rehab and the true post-acute care, high acuity rehab and therapy. And we've been a little bit kind of colloquial or glib, I think, in some conversations recently, but I really believe this. This is kind of a question of, do it right or maybe don't do it. If you're going to do this, I think you've got to be all in. Really, the goal is to be a center of excellence, got to be responsive to what's happening at the acute care level of care. Their discharges aren't coming to you with the low-hanging easy fruit that they used to, right? It's not the low-hanging fruit or easy turnarounds that it used to be. The easy ortho of a couple of years ago is going to be harder and harder to find. They're going to stay home. They're going to be in hospital-driven environments. And what does that mean for your operation? Can you really respond to these complex care needs? Are you equipped in terms of an operation to be that true go-to, a preferred provider, preferred referral source? And most importantly, also, can you staff it? big questions to ask about how you're going to play in the post-acute care space. All right, I'm waiting if there was a lag. Okay. And then at home, again, Karen had mentioned how in-home is becoming more and more pervasive and more impactful on the model. And what role is at home going to serve in your community? I think the question you want to ask is this supposed to be getting to a marketplace to reach beyond your bricks and mortar, folks that are never going to move in? We've all seen those models about just the 3 to 5% actually move into your community. So there's this huge universe of folks that don't. Is this a platform to meet some of their needs because they never were going to move in? Or, as we talked about with assisted living, possibly, is this more of a mechanism to replace or circumvent things that used to be bricks and mortar and doing it in a way that's better for reaching the consumer and the outcomes? But one real important consideration is if the justification here or the driver for use of at home is that, well, you know what, this will be less expensive for the consumer. Let's just make sure we think about that before we use that as the reason to do this. Reality is, in some cases, consumers spend a lot more staying in their home once they get into really high acuity 24/7 care. So if the whole driver was just cutting costs for the consumer, maybe that's not actually the case, and they really are better served. And you want to make that argument if you move into our bricks and mortar settings. Okay, and a question that I think everyone comes to at some point is, do we do something ourselves or do we partner? And the key here is, I think let's make sure we don't just start the conversation with, are we partnering someone, as much as figuring out what do we need and want to be? And then are we equipped to get there ourselves, or does it make sense to look for a partner in helping to execute this? Let's start the conversation with the question of what we need to do and what we need to be, and then figure out how to get there. Some really interesting conversations I have with providers recently, and I'll try to keep this short, but it was really enlightening, where one provider does not actually have a built to purpose environment for dementia care on their campus. And I was like, well, why? Certainly that's a core part of the continuum, isn't it? They said, well, in our experience, there's only maybe a handful of folks that we've had to move out of this community over a number of years. And we always ask ourselves, why should we bother doing this ourselves if we're really only serving a handful of folks that would have needed to move out? And we can work with partners to better do this. Folks who do this day in and day out and are already established. Why take on this risk and this level of care ourselves? Now, for every one of those, I probably hear 5 more tell me that we need dementia care. The lack of dementia care is a challenge to our continuum. It's even impactful at the point of sale. So there's always multiple angles to consider. And then, an idea of partnership, a community we're working with in Ohio, is very similar to a not-for-profit friendly competitor, co-opetition as we call it, that's not too far away from them. Both are struggling in multiple levels of care right now. Are they better served figuring out a way that they can come together on this, so that one is providing one level of care and another is focusing on the other, and kind of the sum of the parts works better than they do as individuals? So a couple of things I want to just hit on real quick in what we'll call mini case studies here. One is a community, very mature CCRC, what I'd call, or life plan community, kind of a class A provider, strong financially, has traditionally been very strong in its occupancy. And how are they reacting to all the trends that are going on, and how COVID has been impacting them as well? They knew a couple of years ago that they had more nursing beds than they needed. They had 60 nursing beds. They haven't filled close to 60 for a while. COVID came, and that occupancy that was already below traditional budgets has taken even a bigger dip. So they've looked in the mirror and they've asked the very hard question of, do we really need this many nursing beds? And their belief is nothing is coming back to where it was a few years ago. And they are better served finding an alternative use for that space, as opposed to thinking that they're going to rebuild census within their nursing home. So it's become a big question of just really, what is the minimum number that they need in order to support their operation and matriculation through their levels of care? And then what to do with that underutilized space? Does it pivot to that concept we talked about earlier, that maybe you still serve a similar kind of acuity, but you try to do it through an assisted living license as opposed to operating nursing? Or think bigger with that space and what else could that space possibly be used for? Is that actually an appropriate location? Maybe not even the footprint of the structure itself, but that location on campus, could that be better utilized to fill another need, such as they could really use a bunch more 14 to 1700 square foot apartments on their campus? And a second example that's very interesting because it's the other end to me of the spectrum here, is what a campus that has always traditionally been a nursing provider that is growing and evolving into a little bit more of a full service life plan community, where they've been dominated by long-term care for years and only have 40 cottages on their campus. And they are thinking about what's the right model for the future. They firmly believe they have too many nursing beds, but they also firmly believe in their ability to operate a really robust rehab and post-acute care program. So what they are thinking about is what's the right sizing and what's the model look like for the future if we really double down on our rehab exposure, because we believe we can operate that very efficiently and very effectively, have great provider relationships, referral relationships. But some of the traditional long-term care that we might have done in the past, which honestly has been away on the operation, what if that goes away? And then, adding a little bit of a wrench or a little bit more complication to the decision for this community, their nursing home sits right in the middle of campus on the prime real estate with great views, where you probably want it to be just about anything other than what it is. So how do they solve that for the future? And they are right in the mix right now of asking and trying to answer these questions. So a couple of quick lessons learned from them that I think are maybe impactful for other providers is, with the conversation about downsizing nursing, had a little bit of a rocky start to it. And a lot of that was from a board perspective about mission. It's our mission to have these beds. This is what we've always been. We serve the community, we serve a lower income through this. And part of the argument is going to be that even if we do lose nursing beds, what if we're still serving the market, maybe even finding ways to put people in more appropriate settings, meet them where they should be, provide and produce better outcomes by losing some nursing beds, but creating other things like a dementia care unit, or maybe even traditional higher acuity assisted living that did not exist on the campus previously. And thinking about all of this just in the context of, if it's not sustainable, right? You know the expression, no margin, no mission. Well, if it's not a sustainable model for the future, then it doesn't work. So we can't be so hung up on mission in and of itself that we don't figure out a way to appropriately sustain and provide the mission. And then another lesson through working with this provider has been, they felt really good about their operating model. And we talked about a lot of concepts for an environment. And what we realized is, we don't want to create an environment and then put an operating model and try to jam an operating model into it. We've got a good operating model. Let's build around it. Let's think about the structures and the environments that facilitate and support that operating model and can enhance it, and build from what's good, rather than trying to just focus on fancy spaces because everyone else is building that, and then try to shift your model. It's harder to change your model, I think, than it is to change your environment. I know the environment takes time and costs a lot of money, but in a lot of ways, changing that model can be even harder. So if you got something good, stick with it and build around it to supplement.
All right. Thank you, Mike. So Mike addressed the part of our topic today of the evolution of the healthcare side and downsizing, and in some ways, not necessarily de-emphasizing that, but there are lots of ways that we just simply don't need as many beds in the future as we did in the past. And what can we do with that space? And more importantly, what can we provide in our communities that others can't, that will still make people want to move to our communities? And that's where Tom's going to share with us a vision for the Fountain of Youth Life Plan community style. Tom, let me get you control here. Always have to click twice there. Okay, you should be good now.
All right. Well, thanks, Rob. And now, before I get talking about the proverbial fountain of youth, I want to talk a little bit about why this concept, the fountain of youth, is so important. And so if you're a CEO, now's definitely a time to listen up. And I believe, quite simply, that the wolf is at the door. As you are probably already aware, most people would prefer to age in their home as opposed to move to a life plan community. In fact, I think less than 10% of the age and income qualified audience that would qualify for a life plan community ever elects to do so. And my suspicion is that that percentage is about to get worse. Why do I think that? Not to be too gloomy here, but because Amazon, Amazon Pharmacy, Walmart, Uber, Apple, Google, Ring, telemedicine, and home health agencies are all working against the life plan community model. They are all telling our prospects that the smart play is to stay at home and they can help, which, as a reminder, is what they want to do anyway. They want to stay in their house without any prodding. These communities, these companies I was just talking about, the Amazons of the world, are ruthless competitors with huge war chests. These are companies that just have an unending thirst for profits. And now they are coming for your market. So, and let me see here. Let's see if I can switch the screen. Oh, there it is. All right, perfect. So, you know, if that wasn't gloomy enough news, I think we have really an adaptation accelerator in COVID. I think the Delta variant will accelerate this trend. And as people become afraid to leave their houses, they will more readily adapt technology. So that will make this at-home competitor an even tougher competitor. I think about how many of our seniors or elders have become accustomed to visiting their families with Zoom. If that doesn't tell you how quickly they're adapting technology, I'm not sure what will. Now, let's see. Those extra years, by the way, back to those extra years of living longer. So unfortunately, we have done a great job. The US has done a great job of making advances in medical and scientific technology. But those advances haven't done much to compress the morbidity stretch in our culture. And so we've gotten really good at live long and dying long. We've gotten pretty good at adding years to our lives, but not adding adding life to our years. So to continue to maintain or progress, what we're really looking for is live long and die short, which, by the way, is the title of one of my favorite books written by Dr. Robert Landry. And based on research of healthy centenarians across a multitude of cultures, one of the consistent traits amongst those of the outliers is really an outlier attitude. These are people who, quite frankly, they tend to defy the expectations of this culturally defined life segment, that they're not accepting they're old. And quite frankly, they're looking at, how do I age successfully? And I think this is the key to staying relevant in the market, is really delivering that fountain of youth. So I also believe, as an aside here, that we're on with the collision of nanotechnology, biotechnology, the mapping of the human genome. We are living in one of the most interesting points in human history. And we're looking at where how we age will significantly change. In fact, there's one professor, Dr. Aubrey de Grey, who thinks that the first person who will live to be 200 has already been born. And So related to this, one of the things I've always thought is that life plan communities offer a closed loop opportunity to truly change healthcare, that we could be proactive instead of reactive. In short, I believe that life plan communities can be the proverbial fountain of youth. This is our kryptonite against those large companies I was talking about earlier. This is what they can't compete against, that closed loop opportunity, a holistic approach to successful aging. As I think about it, the wealthiest, most educated CEOs in the country take advantage of executive health care programs where they spend a day or two getting a full baseline assessment, and then they walk away with a prescribed wellness plan. Typically, this is done at places like Hopkins or Mayo or the Cleveland Clinic. The successful CEO meets with the physician, gets a stress test, a VO2 max, an EKG, meets with a registered dietitian, an exercise specialist, a clinical psychiatrist, radiology on site, and then they get the physician wrap up and they walk away with this prescription of how to be healthier people. Well, the challenge with this, though, is that you then have to walk back into your normal life. I'm going to show you a short video of what one of those typical executive health evaluations looks like. And then I want you to think about how we as life plan communities can adopt this model and even improve upon it.
Proactive management of one's health is just absolutely critical. I mean, you just can't go without it. And that's really what this is all about for me, coming to Cleveland Clinic, is staying on top of my health.
All this attention to detail, you get a report which is very comprehensive. You can learn a lot about yourself and improve yourself, a location, and then is the speed of everything happening, so you don't feel you waste time.
To date, if you look at the normal medical model, it's very disease-focused. It's very doctor-patient driven, whereby patients can participate, but not to the point that there's any kind of behavioral change in their participation. Where in Cleveland Clinic Canada, what we want to do is we want to see the patient before disease. We want to look at how can we see that patient in another way to prevent, hopefully, disease from coming. And in that, the patient becomes the focus of the wheel. That's patient-centered. And with that in mind, you try to organize the patient up so that they themselves take ownership of lifestyle modification.
It's a total investment, not only in what's going on with them now, but really what's going to happen to their health in the future.
The day consists of a 5-hour on-site day. The nurse will take your vital signs, do tonometry, which is a test for glaucoma, spirometry, which is a test for lungs, and also do a hearing test. You'll meet with a phlebotomist who takes blood from you, and we do a screening panel looking at your hemoglobin, make sure your liver is okay, make sure your kidneys, you're not diabetic, a whole bunch of tests. The other providers include a dietitian, exercise physiologist, psychologist, and you'll also have a stress test. You'll have radiology if that is necessary for your day, bone mineral densities, mammograms, or ultrasounds. After that, you have an hour with the doctor. During that time, you'll have a history, physical. They leave here with a prescription, which is much different than giving a medication. They leave here with a prescription that they can take throughout the year and hopefully throughout their whole life to change life behaviors.
So I always thought that life plan communities could mirror this model and make it even better. About, I would say about 10 years ago now, I started my own personal search for what I consider the Tesla of senior living. And that's when I stumbled upon Moorings Park. And they had just opened the Center for Healthy Living. And I snuck onto their campus to take a bunch of pictures, which I quickly started using in my Loving Company presentations for leading age events. And I was just intrigued by this model because they were really taking the executive healthcare retreat and rolling it into daily living. See if I can get the slide to change here. Now, you know, that was one of the hardest decisions of my life. A little over a year and a half ago, I decided to leave my cushy job at Love & Company and join the Moorings Park team. And there were a couple of things that grabbed my attention about the Moorings Park community's approach. And by the way, we have three communities here in Naples, Florida. As far as I know, we are the only not-for-profit life plan community organization that includes concierge physicians in our monthly service fees. The second thing is that to qualify to live in our communities, prospects have to pass a wellness assessment that includes both a fitness and a cognitive component. This assessment we call the Moorings Park Assessment Protocol, or the MAP. And that the MAP was developed by 2 Johns Hopkins fellows. So in addition to our concierge physicians, Moorings Park always has at least 2 Johns Hopkins fellows on our staff. In fact, right now we have 3 on staff. And our residents and our physicians also have special access to Mayo Clinic specialists, including e-consultations in a specially designed medical teleconference room that we have at each of our centers for healthy living. So that technique, by the way, allows our residents additional access to cutting edge advances in medicine and an extended system of care and providers. So anyway, back to the map. The map, oops, let's go back one. The map, the first time a new resident comes into one of our fitness centers, they are met with one of our fitness specialists who develops a customized fitness program based on their MAP assessment, which could include work in our cognitive zone. It could include a physical component. And this MAP assessment becomes their baseline from which to build upon. The real magic, and this seems like it should be the easy part, but it's not in real life execution, is to have the residents' progress reports flow back and forth seamlessly between the fitness specialists and the resident's concierge physician. We now have our docs prescribing fitness activities to the resident, which our wellness team then makes sure to carry out. And very often this prescribed wellness activity is a direct result of the feedback from the fitness specialist. Also, weaving into that plan, that fitness or wellness plan, is the resident's dietary needs. And so it's a much more holistic approach because all of the specialists are under one roof. And so again, the fitness specialist can walk over to the concierge doc and say, hey, this is what I'm seeing. In turn, the concierge doc can prescribe something that the fitness specialist is supposed to carry out. So does this approach work? Well, on a base level, an easy eye test, I would say yes. The average mortality rate in Florida is 78.9. The average mortality for a Moorings Park resident is 94. We are also, by the way, doing additional research to see how we are able to move a person through particular or specific health-related issues, and so we're looking at that. But you know, again, those average age only count if they're quality age or quality years of improving your health. You want healthy years, not just additional years. Now, a couple other things worth mentioning that we're doing, and really, by the way, my purpose of sharing all of this is that you all steal it and use it for your own community, because I think that's the mission. That should be the mission for all not-for-profit life plan communities, is to share. And so a couple other things we're looking at. It's our belief that boomers in particular want to take care of themselves spiritually, physically, intellectually, and emotionally, rather than being taken care of. So we want to, as an industry, I believe we want to move from a hospital mindset to a hospitality mindset. And the organizations that grasp that quickly are the ones that will separate themselves. Anyway, our innovation team is currently looking at wearables like the Apple Watch, the Whoop, or the Oura Ring, one which I'm wearing right now. All of these tools that track personal biometrics and how we might incorporate those personal biometrics into their wellness plan, and even further improve our approach to successful aging. Now, I will tell you, that being said, that's not as easy as it sounds. We're bumping into all sorts of HIPAA complications about how that information is transferred to the docs, but nonetheless, we are headed down this path, and we are aggressively pursuing it because we think it's valuable. You know, here's how I think about aging. I think this is what our customers coming up through the pipeline are looking for. They want to skid across the finish line of life at high speed. You know, if you go back to live long, die short. We all want to have very, very healthy lives right until we pass. And that's the goal. I think if you can incorporate, or better incorporate, how your team is working holistically with the docs, and if you don't have doctors on your staff, thinking about how to increase or strengthen that partnership becomes incredibly valuable. And so with that, skid across the finish line going, holy cow, what a ride.
All right, thank you, Tom. And thank you to all of our panelists today. I think the key takeaways we wanted to share with you were, you know, to be successful inside senior living, we really need to look closely outside of senior living. What are others doing in other fields, and what can we learn from that? It's not just what our competitors are doing, it's where is society going, and how do we keep up with that? And then next, as Mike talked about, you know, the prominence of care and the messaging and the positioning of our organizations, particularly in terms of beds and space, is changing. But for that which we do keep in our continuum, we absolutely have to be the best at what we do. And lastly, Tom, I just really agree with this. I think we have a tremendous opportunity as a field to take advantage of all the resources that we have within our life plan communities and find ways to integrate them, integrate the data, integrate communication, integrate planning to truly create personalized wellness and prevention programs. So hopefully you all appreciated this today. As we noted at the beginning, we started collecting questions throughout. If some of you have been holding on to your questions, please go ahead and type them in the Q&A part of the Zoom control panel now, and we'll get started with that. So the first one that I'd like to bring up relates, Karen, to your dining comments, but really I would ask all of us to respond to it. The question is, with more and more of our prospective and current residents having a portion of their dining experience somewhere other than home, either their current home or when they move to us, Are you seeing any communities doing anything innovative around partnering with dining venues in the larger community? Any innovative ways of looking at how a community with a meal plan potentially reimbursing a resident for a meal they eat and pay for off campus? So this has definitely been something that's been on all of our radars, I'd say at least 10 years now, looking at that flexible dining program, particularly as we look at moving into urban areas and walkable communities and being able to take advantage of the many resources that are around us. We were involved in the planning for a life plan community at a major national university, and they have land on the campus in which they could develop a life plan community. It's still in the early planning stages. One of the fundamentals of that was that the resident's card or whatever device they wind up using to track such things would be usable not only at the community, but it would be their pass to get into the gym, the aquatics center, or any of the dining venues in the community, and be able to use those facilities and have it just automatically charge back to the system. Now, that's theory. Can I list communities in particular that have done this and are actively implementing it in their community? No, I can't. Tom, Karen, Mike, do you know of any that are actively doing this?
I will tell you, Rob, that we're here at Mornings Park, we're actively looking at how we might partner. I'm of the belief that boomers in particular are looking for more flexible meal plans. I think a good model is probably 15 meals a month as opposed to the 30, and then really looking at how you can make that sustainable. I will tell you, we are offering 15 as opposed to 30 on one of our campuses, and that flexibility is enjoyed very much by our residents. We're also looking at, as this person suggesting, how do we partner with local restaurants to make that part of the programming. But I think the first version of it that's simpler is to just reduce the number of days. And actually, our program isn't days, it's a point system. And so residents can use their points as they wish.
So Tom, this is my question, not from the audience, but just as a follow-on to what you shared. As you reduce that meal plan, that basic quote unquote required part, are you finding that people are still continuing to use a lot more than the credits? And does that provide a good margin for you? Are you still seeing good volume levels at all the venues?
Yeah, so it's kind of interesting. The community where we have the 15 as opposed to the 30 is one where included in their monthly service package is membership to a adjoining country club, a very high-end country club with about 6 additional restaurants on site. And so in addition to the restaurants we have on site, they have access to the country club restaurants. And so it's probably not the norm model, and probably wouldn't be a good measuring stick for other communities unless they're going to have that sort of partnership.
So Rob, I think that there's a couple of, go back to Mike's model, questions we need to ask ourselves is what are some of the purposes for doing that? I like Rob, can't point to specific communities who have created off-campus relationships, but I do think that there are the questions of, are we trying to create diversity for residents? Are we trying to engage with our community? And that would be a really big, important question to ask. And especially now, right after COVID and during whatever we have going on at this time, which is an ability to potentially support some of our small businesses in our communities, which is really something worth looking at. We did have a lot of discussions with organizations in pandemic to do gift cards and things like that. So I think that's something to really look at and consider. And then one thing we do see, of course, these days is use of food truck days or summer days or evenings, or which again are engaging a community resource as well as creating a diversified excitement option and experience for residences on campuses.
All right. Thanks. Mike, did you have anything to add to that part? Okay, well, I do have a question for you, Mike. And in your section, you focused very heavily on, which makes total sense, existing communities, how to step back and look at their healthcare, continuum and think about how to evolve that in the future. What about a brand new community, coming out of the ground? Are you working with any there, and how are you planning that part of the continuum, say from the total startup, if you can invent it from scratch? How are you looking at it there?
Yeah, it's a great question, Rob. And I think it's a little bit of a similar question of how much do we need? And there isn't one answer for each community, right? For each community, it's a little bit different. But I'd say the trend that pulls it all together is less healthcare overall. And when you think about the ratio of the model of independent living to the totality of long-term care, it's less long-term care than maybe even models came out of the ground 10 years ago. In some cases, maybe it's bypassing assisted living and saying we just want nursing. We can think of several models, and some high-profile ones. Karen, you'd mentioned Enso Village in California, which is not going to have a nursing component on campus and is looking to partner off campus. So taking pieces of that continuum, pulling them out all together is a trend that we're seeing in a lot of startups. And part of that is just simply financial execution. It's very difficult to finance the healthcare up front. Maybe it's a later phase, or maybe an organization wants to see, can we actually manage this process with an at-home platform, with a partnership, and not ever need to take on the risk, both operationally and construction and finance, about building healthcare.
All right, thank you. We had a follow-up question on the dining part. And Tom, it wasn't specifically addressed to you, but I think it probably is. And then we may also have others of us contribute to it. But the question is, within the credit model of 30 or 15, whichever that might be, is dining the only current area the credits can be used towards?
Great question. And by the way, I should mention, we are in the process of currently reshaping our point system as we speak. Right now, and I suspect in the future, yes, the answer will be that the points only work in the food and beverage area. I also suspect that we will be separating out alcohol and taking that out of the point system, and that if you want alcohol, you would pay for it with a credit card. Credit cards are accepted in our restaurants and our spas and salons as well. But we're trying to create a point system that is fairly measured and equitable for all involved, and also approaches our attitude towards successful aging.
All right, thanks. And I also do know of communities where it's not a point system, but it's $1 credit that they have each month that they can use in a variety of ways. They can use it on dining, their own meals, guest meals. They can use it for a massage, for salon services, pedicures, manicures, a wide variety of services. They can use it to buy things from the store in the community. It's just a flexible pool of dollars. So I definitely know communities that do that. Tom, while we have you, actually some of the remaining questions do focus mostly on you. Can you tell us more about the ring you're wearing?
Sure. So this is a Aura ring, and it measures, quite frankly, its primary focus is to look at successful sleep. Scientists are finding that sleep is one of the most underrated variables to successful aging. It also has direct links into dementia and Alzheimer's. And so my ring measures my resting heart rate, my body temperature, really looks at a whole bunch of different variables, much like the Apple Watch or the Whoop, and is very non-invasive, unlike a watch. It's easy to wear to bed. Interestingly, it's also been a pretty good indicator of when someone's getting sick. And in fact, Aura has been using it in tests to see if it can indicate when someone's getting COVID. I will tell you I track it and look at it every day. And as an example, my body temperature was elevated last night, which may indicate that you're coming down with a cold or something. And so it's something I'm going to be paying attention to. I also pay particular attention to my deep sleep, which is when your brain essentially cleans out all the junk or synapses, cleans your synapses out. So it's just another biometric tool that is very useful.
All right, thanks. And our goal to everyone is to try and wrap up by 1:28. So let's see if we can squeeze, I'm sorry, by 1:30, it's 1:28. So let's see if we can squeeze in one more. Also to Tom, or it could be to anyone if you have insights, but have you experienced residents that are not wanting to change to your in-house physicians and wish to keep their own?
Absolutely. Mornings Park serves a very, very affluent group of people, and they tend to have concierge doctors of their own even prior to arriving in our communities. That being said, what you see is that they typically will hold on to their existing concierge doc for a year or two. And then when they see the convenience of having the on-site concierge doc and how that integrates holistically into our broader approach, they typically will make the switch after 2 years.
All right, thank you. And with that, I think we're just running up to the end of our time. So to all of our guests today who signed in for this, we really appreciate you taking the time to join us. And if you missed the beginning, part 2 of this series of repositioning life plan communities to offer what consumers really want, will continue in September. So please keep your eyes out for that. And to Karen and Mike and Tom, thank you once again for your time, sharing your thoughts, your insights with Senior Living Field today. We really appreciate the time and effort that all of you put into this. So take care, everyone.
Thanks for having me.
Thanks all. Bye.